It does lots of things. It's not just for gas exchange, right? Gas exchange is going to be one of the key components in the respiratory system. But for us, we also, the respiratory system also involves other things as well. So, for instance, here's one word, olfaction. You guys know what olfaction is? That's what? The sense of smell, right? So your olfactory bulb is going to be associated with your sense of smell. So respiratory system is tightly associated with smell. Respiratory system is also associated with something you find in your larynx. What's something that you find in your larynx? Your voice box, your vocal cords, which I'm hoping my vocal cords will work for the rest of today's lecture because I'm feeling a little hoarse after getting over an illness. So communication is going to be really important in the respiratory system. Obviously, gas exchange. Something that goes along with gas exchange is acid-base balance. Now, as you become hypercapnic, that's the term that we use for an excessive amount of carbon dioxide in your system, then you start becoming more acidotic, right? And so in order to balance that out, what you can do is to increase your respiratory rate, so you're breathing out more carbon dioxide, and now you can help to bring your pH back up again, so you can become more alkalotic instead of acidotic. And so the respiratory system is going to be very tightly associated with acid-base balance as well. Immune system function. So remember we talked about MALTs. Those are your mucosal associated lymphoid tissues. Those are found throughout any mucosal membranes. GI tract, genitourinary tract, but also within your respiratory system as well. There's going to be a lot of leukocytes found within your respiratory system because your respiratory system, you're going to get a lot of pathogenic organisms entering into your respiratory system, so you have to be able to fight those off. So we're going to talk a little bit about like bronchitis as well as like pneumonia. We're not going to go into it in too much detail, but those are some illnesses that are associated with infectious pathogens. Dehydration. What happens if you speak too much? You start losing water, right? You start losing water through water vapors. So if you talk a lot, you're going to be losing water. If you're exercising and you have your mouth open while you're breathing, you're going to lose a lot of water. That's why it's recommended when you're exercising, try to keep your mouth closed and breathe through your nose. That'll help you reduce your water loss. Platelet production is also heavily implicated in the respiratory tract. So a lot of your megakaryocytes, which are the precursors for platelets, are going to be found within your lungs. And then we're going to get into flow, the different dynamics involved in ventilation a little bit later. But other things that the lungs can help do is help to reduce clot formation. So if you get a blood clot somewhere and it winds its way into your respiratory tract or respiratory system, your lungs can help to try to reduce or break down those clots. So throughout chapter 22, these are the different things that we're going to be able to do. So eventually, we're going to be able to identify all the different structures that are implicated in the respiratory tract. We're going to talk about gas exchange and how that actually takes place. Most of it's going to be just through very simple gas diffusion. We're going to talk about the three major laws, like Boyle's law, like Henry's law, for instance, that basically determine how gas, like the properties of gas and how that takes place when you breathe. We're going to talk about pulmonary function tests. Pulmonary function tests are going to be something that's done for patients who have asthma, who have COPD, who have emphysema, who even have restrictive pulmonary diseases like pulmonary fibrosis. So we're going to talk about all the different like vital capacity, tidal volume, total lung capacity. We're going to talk about all of that throughout chapter 22 as well. And then carbon dioxide, that's going to be heavily implicated in like base, acid-base balance. So we'll get into all of these topics throughout chapter 22. So the respiratory tract is going to be broken down into two major components. You're going to have the conduction portion, and you're also going to have the respiratory portion. Conduction just means that's where air goes. That's how air travels. So the conduction portion is going to include everything that allows air to enter into your lungs. So we're talking nasal cavity, pharynx, larynx, trachea, and the different bronchi. So you have primary bronchi, secondary bronchi, tertiary bronchi, etc., until you make your way down to the alveoli. Once you get down to the bronchioles and the alveoli, that's where you're going to start seeing gas exchange, especially in the alveoli. The bronchioles help to determine the amount of air that goes into the alveoli because the bronchioles are going to be predominantly implicated in bronchodilation and bronchoconstriction. So if you constrict your bronchioles, you're going to reduce the airflow. If you dilate the bronchioles, you're going to get more airflow. So we're going to talk about that later on. So this is an overview of your respiratory system. Now, depending on what textbooks you look at and depending on what literature you look at, the respiratory tract is going to be divided into upper respiratory and lower respiratory. The border of demarcation, that's what's going to kind of vary depending on what literature you're looking at. But a pretty good rule of thumb between upper and lower respiratory is what I'm using right now, my vocal cords. So your vocal cords are going to be found within your larynx. And your larynx is going to be subdivided into the upper and lower portion of the larynx. But the vocal cords are going to be what determine upper respiratory from lower respiratory. So if you have a upper respiratory infection, that's going to be anything that's above the vocal cords. So for instance, if your epiglottis got infected and you had epiglottitis, right, that's going to be considered an upper respiratory infection. If you had any sort of sinus infection, whether it's in your nasopharynx or your oropharynx, those are going to be upper respiratory infections. The moment you go below the vocal cords, that's going to be all considered lower respiratory infections. So bronchitis, bronchiolitis, pneumonia, those are going to be some of the major lower respiratory tract infections. So upper respiratory, to reiterate, is going to be all these different components. So nose, nasopharynx, just the pharynx in general. And then lower respiratory, everything below the vocal cords in your larynx will be lower respiratory. So we're going to get into a little bit more detail here. When you get into lower respiratory, when you get into your lungs, these are some of the anatomical features in your lungs. Your right lung versus your left lung. Right lung is going to have 3 different lobes, whereas your left lung is only going to have 2 different lobes. Quick question, why do you think that is? The heart, yeah, exactly. So your left lung, your heart is going to be residing mostly within like the left portion of your thoracic cavity, right, within the mediastinum. Because of that, you're going to have only 2 lobes in your left lung to help accommodate for your heart. And then in terms of the lobes, for the right lung, you have superior, inferior lobe. You also have your middle lobe. And then it's going to be subdivided through the oblique fissure, which travels obliquely. And then the median fissure is going to, or the horizontal fissure is going to be able to help separate the middle lobe from the superior lobe. And then in your left lung, all you have is the oblique fissure to subdivide the superior from the lower lobe. And then other things that are important in terms of features, the apex. So the apical area is going to be the top, the most superior portion of your lung. And then at the very bottom, you have the base of your lung. And then you have the cardiac notch, which is going to accommodate the heart. And then on top of that, another thing to keep in mind here is on your left lobe, you're going to see the area that's going to accommodate the aorta. So as you see over here, you have the area that's going to be accommodating the curvature of the aorta, and then the descending aorta, moving down from that, which goes into basically the thoracic aorta, and then once you penetrate through the diaphragm, then you get into the abdominal aorta. And then the hilum is basically going to be the opening that allows for all the different vessels as well as the bronchi. So you have bronchi, pulmonary vein, pulmonary artery, as well as lymphatic drainage coming out from the hilum. Now, the epiglottis, one thing to keep in mind about the epiglottis is that it's going to help prevent food from entering into the trachea. Right? That's the major role that the epiglottis is going to play. So whenever you swallow anything, food, water, your epiglottis is basically folds back, and then it's going to cover up the opening into the trachea, so it allows food to enter into the esophagus instead. And then in terms of location, the trachea is going to be more anterior versus the esophagus is going to be posterior. Right, so the trachea is going to be characterized by these semicircular cartilaginous rings versus the esophagus, which is just basically smooth muscle. Other areas, other anatomical features to take note of. You have different concha, which are going to be found within your nose. So you have a superior, middle, and inferior concha. The nasal vestibule is basically the first portion of your nose before you get into the concha. And then we're going to talk about the roles in a moment that the concha plays. Basically what happens in the concha is that you get a lot of turbulence in the airflow. So the air sort of like slows down a little bit once it's entering into the nasal passage. And within that turbulence in the concha, you're going to get maximum like contact with the mucous membrane. So it's going to allow for warming up of the air entering into your respiratory tract. The warmth of the air is going to really help a lot in terms of oxygenation, which we're going to talk about the dynamics of that later on, but the temperature definitely has a huge role in the ability for your red blood cells to get oxygenated properly. Between your concha, you're going to have different meatuses. Okay, so you have meatuses which are going to be all found in between each of these different concha. And then here's another image of what that looks like. This is going to be a coronal cut of the skull. As you can see, all these different concha, they're going to have, the shape allows for a great amount of turbulence when the air passes through these areas. Okay, we already talked about that. Cool. So as I mentioned earlier, that you have a lot of, not lymphatics, but you have a lot of white blood cells, you have a lot of immune response within your lungs, because you're constantly breathing in things like spores, right? Fungal spores. You're breathing in like viral particles. You have a lot of bacteria as well. You're breathing in bacteria as well as some of the potentially pathogenic bacteria that you find within your oral cavity. For instance, a lot of us have Streptococcus pyogenes within our oral cavity. When you guys do your microbiology labs later on, you do throat cultures. Generally, in my classes, about 25% of my students are going to have beta hemolytic bacteria within their mouth. Those are going to be the types of bacteria that can potentially cause disease. You also have Streptococcus pneumoniae within your mouth. You have lots of different types of bacteria in your mouth that could potentially cause disease. Why do they not cause disease? Well, first you have your normal microbiota. Your normal microbiota helps to defend your body from any pathogenic organisms, right? So they compete for resources. Sometimes they even release different types of toxins to keep other bacteria at bay. But on top of that, you also have cilia found within your respiratory epithelium. So the mucociliary escalator is going to be one of the most important things that helps to keep potentially pathogenic things from entering contact with the alveoli. So these cilia are going to be batting in a unidirectional fashion up, so that anything that goes down into your trachea, down into your respiratory tract, can eventually make its way back out. You're also going to have a lot of antimicrobial proteins found within these areas. So like defensins, for instance, are going to be able to help to fight off microbes. And then lysozyme. We talked about lysozyme as being something that's secreted by your tears, as well as mucosal membranes. You're also going to find lysozyme within the respiratory tract to be able to fight off any potential pathogens. So here's kind of what that looks like. You got a mucociliary escalator, and then everything basically just moves up in one single direction. So that's going to be a really huge, important role in keeping your respiratory tract free from any sort of pathogenic microbes. Now, we talked about the humidification of air, right? The humidification and the warming up of air is going to be really important to allow for maximum gas exchange. So your red blood cells are especially going to be able to take on oxygen when the air is a lot warmer. And so when you're breathing in, that's what's happening within those nasal concha. It helps to basically warm up and humidify the air. So if you want to try to prevent water loss, that's try to keep your mouth closed and breathe just through your nostrils. That's one of the best ways to do that. And this is just a side note, epistaxis. Have you ever heard that term, epistaxis? That's just a fancy word for a nosebleed. I don't like what's going on with this poor lady over here. So let's talk briefly about the different sinuses that you find in your skull. The main purpose of the sinuses within your skull is effectively just to keep your skull from being too heavy. So the sinuses effectively allow for a reduction in the overall weight. Other things that the sinuses help do is just warm up, moisten up the air. But if you get infections, like an upper respiratory tract infection, you can also get secondary consequences from that. You can get sinusitis as a consequence. Any of the sinuses can basically be affected by sinusitis. So you have a couple different sinuses. The one in the front is going to be your frontal sinus. You also have one that's a little bit further back, is the ethmoid sinus, maxillary sinus, and sphenoidal sinus. The maxillary sinus, if you have a patient in the future that has any sort of like tenderness on their cheeks, you can actually just tap on it, and if that causes pain and they have sinusitis, then you know that they have like maxillary sinusitis. Frontal sinus, you might be able to tap on their the frontal area of their skull, and if it causes any pain or discomfort, then you know that they probably have some sort of sinusitis taking place. So this is beyond this class. This is just infectious diseases, right? And the types of infectious diseases that can affect different areas of your respiratory tract. Upper respiratory tract infections versus lower respiratory tract infections. In your upper respiratory tract, some of the most common causes are going to be viral. So a lot of different viruses are going to be causing upper respiratory tract infections. Some of the key players are going to be things like rhinovirus, adenovirus, even like influenza. That's going to be mostly affecting upper respiratory tract. Rhinovirus is especially common. If you ever hear the term rhinovirus or rhina just means nose. If you hear rhinorrhea, that means the person's got, runny nose. That's what rhinovirus causes. Basically just a runny nose. Nothing really too crazy. Once you start getting into the lower respiratory tract, then you start getting viral infections, but also you start seeing more bacterial infections as well. For instance, pneumonia. You can get viral pneumonia, you can get fungal pneumonia, you can get chemical pneumonia as well from like pH. If you aspirate, you can get chemical abrasion from that. But most commonly, the more severe types of pneumonia are going to be caused by bacteria, like Streptococcus pneumoniae, for example. So I just included this over here so you can see how these different regions are going to have different types of infections associated with them. These are the types of infections that you see with upper respiratory tract illnesses. So sinusitis is going to be a common theme. Pharyngitis, it's kind of what I had earlier this week. It was pretty terrible. Epiglottitis, this is a very severe infection of your epiglottis. Like, remember, epiglottis folds back to help you prevent getting food or water or whatever you're drinking into your trachea. If you have epiglottitis, you get a massive inflammation of the epiglottis, and it can potentially compromise the person's airway. It can actually make it very difficult for the person to breathe. It also makes it very difficult for the person to swallow. Patients that have epiglottitis, they start drooling because they're not able to actually swallow saliva. So one of the biggest concerns is maintaining their airway because it can become very severe. Croup is another common illness that happens upper respiratory. It especially affects children. One of my best friends just called me about 3 weeks ago, and he told me that his kid was having these intermittent fevers that would be most predominant at nighttime, and he would have these coughing spells. The coughing spells were so severe that he would vomit after the coughing spell, which is a very common theme with croup. When people have croup, generally you just give them like corticosteroids. So the corticosteroids can help to relieve the inflammation. But several viruses cause that. It's like respiratory syncytial virus, parainfluenza virus. So these are just some examples of upper respiratory tract infections. Sinusitis is mostly going to be due to viral infections, but bacterial infections can also cause sinusitis as well. That friend that I was telling you about, he has chronic sinusitis, which is due to viral infections, but also just due to allergies in general. So some people live with chronic sinusitis. It's not the end of the world. Generally speaking, you can give the patient like decongestants and things like that. It can kind of help reduce the inflammation. You can also give them analgesics like ibuprofen. Sometimes that can help. And if it's bacterial, you can just give them antibiotics. Now the pharynx is going to be subdivided into 3 different sections. You have the nasopharynx, which is, this is the soft palate right here. If you go directly behind or posterior to the soft palate, that's going to be the nasopharynx. When you go directly below that, if you do a tongue depressor and you have your patient open up and say ah, and you actually see the very back of their throat, you're going to be looking at the oropharynx. And then below the oropharynx is going to be the laryngopharynx. That's right before you get into the larynx. Moving on. And then for pharyngitis, this is going to be a very common type of infection. It can happen due to viruses, but most concerning bacterial infections. When you guys get into micro, you'll learn more about this later, but Streptococcus pyogenes. Remember I mentioned that a lot of y'all probably have strep pyo in your mouth, strep pyogenes. That's the number one cause of bacterial pharyngitis, or strep throat, if you will. Now, the biggest concern with bacterial pharyngitis is that it's a good idea to treat those patients with antibiotics if it's a bacterial infection, right? One of the biggest concerns with pharyngitis and even like pneumonia and things like that, if you don't treat it, these types of bacterial infections can easily enter into the central nervous system, resulting in meningitis. That's the biggest concern. And if a patient gets meningitis, especially bacterial meningitis, that can kill a person really rapidly. Sometimes between 12 to 24 hours, the person can ultimately succumb to meningitis. So even if it's something as simple as strep throat, you want to try to treat that with antibiotics. If it's viral, you don't do anything, right? You don't give the person antibiotics for a viral infection. But if it's bacterial in nature, then yes, you want to make sure you treat that. And here's your larynx. This is your quote-unquote voice box. Right? So here's your vocal cords right here. But part of your larynx are going to be several different structures. The epiglottis is going to be one of the major structures that helps, fold back to prevent things from entering into your trachea. Then you have your thyroid cartilage. The thyroid cartilage, especially for guys, is the most prominent protrusion on the neck. Your Adam's apple, if you will. And then below that, you got the cricoid cartilage. And then when you pass below the cricoid cartilage, that's when you start getting into those semi-circular cartilaginous rings that make up the trachea. So the voice box, vocal cords, pretty straightforward. It's going to be associated with the hyoid bone. Now, one of the key things about the hyoid bone is that the hyoid bone allows for vocalization, but it also helps to stabilize the tongue. So it's going to be one of the structures that allow for structural integrity of the tongue. And then we already talked about the epiglottis, and we talked about swallowing. Now, this is a really fun video that I like to play my students because it's kind of interesting. It gets a little loud, so let me just turn this down just in case. So that is the vocal cord right there. This video is a little unsettling, so. After the nose is numbed and decongested, endoscope can be put in order to visualize both spots. Both adults as well as kids can easily correlate. Let's take a closer look on the inside. Here, the scope is after reaching the very back of the nose, so that lady is she's a vocalist. She's a singer. As shown here, the vocal cords themselves can also be so freaking gross. I love it. Anyone get grossed out by that or what? Anyway, so that's the vocal cords. That's what divides the upper respiratory tract from the lower respiratory tract. And then this is epiglottitis. If you guys, I don't know how the NCLEX exam is, but when you take the medical boards, This is something that we study for epiglottitis. It's a thumb. If you look at the x-ray and you see it looks kind of like a thumb, that is like pathognomonic for epiglottitis. Generally speaking, it's going to be caused by Haemophilus influenza, but lots of things can cause that as well, but it's mostly going to be Haemophilus influenza. The biggest concern with that, because it's, your epiglottis, you just want to make sure that the patient's airway is going to be maintained, because that can easily obstruct the patient's airway. So let's get now into the lower respiratory tract. So lower respiratory tract would be the lower half of the larynx down to the trachea, all the way down into the different bronchi. So the moment the trachea bifurcates, you get primary bronchi, one for each side of the lungs. Then as those primary bronchi bifurcate again, you get secondary bronchi, they bifurcate again, it becomes tertiary bronchi, and then all of a sudden you find your way down to the smaller bronchi, which still do have cartilaginous tissues, but then as soon as you lose the cartilaginous tissue, that's when you get into the bronchioles. And the bronchioles are going to be heavily implicated in constriction and dilation. So if you have sympathetic activation, bronchioles dilate, right? Sympathetic activation, think fight and flight, right? If you're out there jogging, you're running away from the lion, you want to make sure you get as much oxygen into your respiratory system, and so your bronchioles are going to dilate to allow for greater amounts of oxygenation. Now, if you're falling asleep or if you're in rest and digest, then you might go into a parasympathetic response, which might cause your bronchioles to constrict a little bit. I just finished a lab with my medical physiology students, some of which have asthma, and we were doing pulmonary function tests, or spirometry, where you like breathe into a tube and you're able to actually see the different capacities, so like inspiratory reserve capacity, etc., things that we're going to talk about next time. But one of my students said that his asthma generally gets worse at night. One of the reasons being is because at night you're about to fall asleep. Now you're going into like more of a parasympathetic state. Parasympathetic state, you get constriction. For a person with asthma, that's going to make asthma a little bit worse. Other things can trigger asthma too, like cold weather, exercise, pollen, allergies, things like that. So that's going to be mostly taking place at the level of the bronchioles. The trachea, as I mentioned, you're going to have those cartilaginous rings. They're semicircular, okay? So they don't complete all the way around. On the posterior aspect of the trachea, you're going to have a muscle, it's the trachealis. And similar to the bronchioles, when you have sympathetic activation, that's going to help increase the diameter of the trachea, so you can get more air coming into your respiratory tract. And in terms of the conducting zone, so we talked about the conducting zones versus the respiratory zone. Conducting zone is wherever you have air traveling through before it gets to the level of the alveoli. In your right and left primary bronchi, they're going to be a little bit different in terms of their shape and length. For the left bronchi, they're going to be a little bit more at an angle versus the right bronchi. The right bronchi are going to be a little bit more blunted, and they're going to be a little bit more straight. Now, the reason why that's important is because foreign objects. Now, this is on the left side, right? Because you got your cardiac notch, you got the heart on the left side here. Would you expect a foreign object to be winding up in the left primary bronchi more so than the right? Okay, so definitely not. Are you guys learning about this in the lab, anatomy lab? Okay, cool. So I'm kind of beating a dead horse here. So generally speaking, if you get any foreign object, or even just aspiration, like aspiration pneumonia, generally speaking, aspiration pneumonia will also affect, more often than not, the right side, because the right bronchi are going to be a little bit more blunted. And then bronchioles, as I mentioned, that's going to be what involves like the smooth muscles, allows for dilation versus constriction. And then once you pass that region, then you start getting into the respiratory zone. So we already talked about all that. Now, we already kind of went over this, but let's go over it again. The lungs, you have your apex of the lungs at the very top, the base of the lungs at the very bottom, right lung, 3 different lobes, left lung, 2 different lobes. Now, one of the biggest concerns with the apex of the lung, For patients that have a very difficult stick, if you have a hard time accessing their vessels, their veins for IV access, one of the other alternatives would be to go into the subclavian. Now, the biggest concern with going to the subclavian, which is going to be directly beneath the clavicle, one of the biggest concerns is perforating the lung and causing a pneumothorax. So generally, if a patient has a difficult stick and you have to resort to a subclavian access, then you would usually want to use a ultrasound-guided stick. So that's something to keep in mind in the future for any of you who wind up in emergency medicine. That's something you're going to see more in like the ER than anything else. All right, so in terms of lower respiratory infections, so we talked about upper respiratory, let's talk about lower respiratory. Some of the major ones are going to be bronchitis, also bronchiolitis, and then pneumonitis versus pneumonia, and then tuberculosis. Some of the biggest concerns are going to be pneumonia. Generally speaking, bronchitis, it's extremely uncomfortable, but there's not much you can really do for bronchitis except for like albuterol, right? Or you can maybe even do like corticosteroids to try to like reduce inflammation. But generally speaking, bronchitis is going to be viral, right? So you're not going to be able to really treat it with any sort of therapeutics aside from the therapeutics that would help minimize inflammation. Pneumonia, on the other hand, is going to be mostly bacterial. So you definitely want to be able to treat patients with pneumonia using antibiotics. So here's a really good breakdown of bronchitis versus pneumonia. They're both going to have fevers, right? You're going to also see chills, but with pneumonia generally kind of knocks people out. It really affects them. They get really severe fevers. You also sometimes even start getting pallor, you start getting dusky because you're not getting enough oxygenation of your tissues. So generally speaking, we subdivide pneumonia into walking pneumonia, which is like atypical pneumonias, and then all the other types of pneumonia. Walking pneumonias are like are going to be a little bit less severe. You can still walk around, you're still sick, but not as bad, versus general pneumonia, like from Streptococcus pneumoniae. Generally speaking, you're going to be down and out, bedridden, because you're very, very ill. Bronchitis, that's not going to happen when you have bronchitis. Nothing really too crazy. But with pneumonia in general, it's going to be basically a more systemic type infection. I'm not going to bore you with the sounds of bronchi versus crackles, but those are going to be the types of sounds whenever you're doing auscultation with your stethoscope, listening to different lung sounds. You're going to be listening for bronchi, which kind of have these like really deep type of sounds. It's kind of like a deep gurgling sound, versus crackles, which kind of sounds more like your crepitations with like if you're like rubbing plastic, like plastic paper. That's what crackles are. So you can listen to that on your own. Let's move beyond this. We already talked about bronchitis as being mostly viral. If you do get bacterial infection of the bronchi, that can result in whooping cough. Whooping cough is a very, very serious illness that's going to be associated with Bordetella pertussis. Remember we talked about the vaccinations, Tdap, DTaP. That's going to be one of the bacteria that's involved in the Tdap vaccine. So that's tetanus, pertussis. That's what the P is for. And D is going to be for diphtheria. So let's move down even further, down into the alveoli, where you actually see gas exchange taking place. So down at the level of the alveoli, so right before you get to the alveoli, you're going to have your bronchioles. And your bronchioles are going to have lots of smooth muscle. The smooth muscle allows for dilation as well as constriction. And when you get down to the alveoli, you're going to have lots of capillaries because it's going to be highly vascularized to allow for gas exchange. And you're also going to have a lot of elastic fibers in the interstitial space. And we're going to talk about that in a second. Those elastic fibers allow for elasticity of the lungs. So whenever you breathe out, that's mostly going to be a passive action. When you breathe out, you have relaxation of the diaphragm, and then you also have the elasticity, elastin fibers, allowing for a recoil of your lungs to allow air to come back out. So we're going to talk about that a little bit later. In terms of pneumonia, so we talked about the different types of pneumonia. So you have viral infections, bacterial infections, fungi. Those are all going to be at the levels of the alveoli. So pneumonia is going to be effectively any sort of infectious agent or chemical irritants affecting the lungs at the level of the alveoli. And arguably, bacterial pneumonia is going to be some of the worst. With chemical irritants, chemical that's going to be hydrochloric acid coming from your stomach. That's going to be one of the most common causes of chemical pneumonia. That's a person who aspirates, right? They vomit, the GI contents now make their way down the trachea and into their lungs, and that's what causes chemical pneumonia. So here's the types of aspiration pneumonia. So you get the chemicals, which is coming from stomach acid, but you can also get other types of aspiration pneumonia as well. So one of the most concerning ones, you guys aren't responsible for this, but Klebsiella pneumoniae, that's a gram-negative rod that you find in your GI tract. All of us are going to have Klebsiella pneumonia as part of our GI. So if you aspirate and you inhale those stomach contents, that's the biggest concern, is getting Klebsiella pneumoniae. Klebsiella is very similar to Streptococcus pneumonia in terms of its clinical presentation. You get high fever, you get pain like pleuritis, you get productive cough, you have a lethargy. But the biggest thing about Klebsiella is that it's a little bit more fatal. Oftentimes, patients with Klebsiella actually have to get surgery to remove abscesses that begin developing within the lungs. So let's talk about the controls of airflow. Now, as I mentioned, you have a couple different muscles that are smooth muscle regions that are going to be responsible for dilation and constriction. The most important ones are going to be at the level of the bronchioles. Now, if you have sympathetic activation, right, so that's fight and flight, you want to maximize the amount of oxygen that's being delivered to your lungs. And so the major adrenergic receptors that are involved are going to be beta-2 adrenergic receptors. Okay, so as beta-2 adrenergic receptors get stimulated, that's going to result in bronchial dilation. So you're going to allow for more oxygen to be able to come in. That's really important. It also allows for reduction in resistance of airflow. And anyone in here have asthma? Do you guys use albuterol? Right, so that's the mechanism of albuterol. When you take an albuterol inhaler, that beta-2 activation, that's going to allow for bronchodilation, that's going to allow you to be able to breathe a little bit easier. So it alleviates the symptoms of asthma. Side note, with beta-2 receptors, remember we talked about the heart, the adrenergic activation of the heart when you have sympathetic activation, that's beta-1 predominantly. However, you also do have beta-2 receptors in the heart as well. So you do get a little bit of beta-2 activation in the heart, which can cause increased contractility, increased heart rate. But beta-2 is going to be mostly lungs. So beta-1, you have one heart. That's kind of one way to think about it. Beta-2, you have 2 lungs. So that's one way to try to remember what type of adrenergic receptors you have in each. Now, parasympathetic activation is going to do the opposite. It's going to allow for bronchial constriction. And that's going to be moderated by acetylcholine as well as muscarinic receptors. And don't worry about these specific ones. Just know that muscarinic receptors are going to be the major ones associated with parasympathetic activation. Something else that can cause bronchoconstriction. Think about when you have allergies, right? You have an allergic reaction. You're going to have a hard time breathing if it's severe enough, especially if you're getting into an anaphylactic type situation. So you're going to have constriction, difficulty breathing. That can be moderated by histamine release. So whenever you have allergies, that's kind of the mechanism of what's going on. That's why you have a difficult time breathing. If it's, if you have hay fever, if you have allergies to cats, for instance, etc. And then I included this image to show you kind of a breakdown of where the different adrenergic receptors are. This is what we just talked about here. The beta-2 adrenergic receptors predominantly found in your bronchioles, allows for bronchodilation. And then beta-1, that's going to be mostly associated with heart. So that's just kind of a sidetrack on that. And then a side note on asthma, some of the major causes of asthma, it's going to be allergies. Right? You can also get asthma attacks from exercise. Some people have exercise-induced asthma. Temperature can also cause asthma. For those in the room that did have asthma, what are some of your guys' triggers, if you guys don't mind sharing? when you get sick? Smoke, vapor. So like water vapor? Like if you're taking a shower, do you get that too? Too much. Wow, that's wild. You guys, cold air? Cold air makes it worse. Well, it's a good thing you're here in Phoenix, right? Any other triggers for the other? It's better with humidity. Huh, interesting. Yeah, so the dry weather sort of makes it worse for you. So it kind of sucks to be in Phoenix then, huh? So all these different things can affect asthma. Basically, what happens with asthma, it's a obstructive type lung disease, right? When we talk about obstructive diseases, you're talking about obstructing airflow. For COPD, it's air trapping. You get air basically stuck in your lungs. You have a hard time getting it out because you have destruction of elastin. You have destruction of those elastic fibers that allow for recoil. Asthma is kind of similar insofar as you get these little plugs that form. So you have basically narrowing of your bronchioles. So it causes bronchoconstriction. So pretty nasty. In terms of treatment, albuterol inhalers. You can also use other types of like corticosteroids as well. Do you guys use anything else besides albuterol? Do you use corticosteroid meds? So a pill? It was like a corticosteroid pill? Yeah, usually that's when you have very severe asthma. So they will give you corticosteroids. If you have more moderate type asthma, albuterol inhalers are good enough. So these are the other things that you can use to treat corticosteroids. Yeah, leukotrienes, things like that. Those are side note. You don't need to memorize all those different drugs. Major thing though, you should know beta 2 receptor activation. That's going to allow for bronchial dilation. So let's talk about the cells that you find within your alveoli. There's two major cell types that I want you guys to be familiar with. You have type 1 pneumocytes and you have type 2 pneumocytes. The type 1 pneumocytes, they're just squamous cells, basically. It just allows for the easy movement of gases. That's like the major role that the type 1 pneumocytes play. Nothing really too crazy. They're very thin, so it allows for easy, simple diffusion across those layers. Then the type 2 pneumocytes are a little bit different. Type pneumocytes are extremely important because they're going to allow for the production of surfactant. Now, surfactant is sort of a detergent type solution that allows to reduce surface tension. Without surfactant, your alveoli would basically start sticking to each other. Okay? And then they would have a harder time opening up. So they would stick to each other, they wouldn't open up, so you wouldn't be able to allow for ventilation. Now, the biggest concern with surfactant production is that premature preemies, right? Any child that's born before term, depending on what week in the gestational period they are, they're not going to be able to form enough surfactant on their own. So premature babies are generally going to have to be treated with exogenous surfactant, which we're going to talk about in a second. But here's just kind of like a review on just the dynamics of water. Water is going to be a highly electronegative molecule, and so because of its electronegativity, that sort of helps to contribute to its ability to increase its surface tension. And so let's go into surface tension. Surface tension basically is what allows for things like the formation of water drops, also the formation of a meniscus, right? So if you use like a graduated cylinder and you're like looking at maybe, for instance, like a hydrometer of some sort, you look for the meniscus, which is where the water kind of basically sticks onto the surface of the glass, onto the sides. And so that's all due to surface tension. So let's watch a very brief video on this. It's kind of an interesting video. So they're literally just putting water on a penny.
Yeah, that's good. Why don't you put one drop of soapy water into that? Cool. So this soapy water gets in, it destroys the surface tension.
So that's kind of what surfactant does. Surfactant basically acts as a detergent, and as a detergent, it's going to help to reduce the surface tension of water. So it's going to prevent that tendency for water to stick. So this is all just kind of FYI. This is from like either like a test tube or a graduated cylinder. You'll be able to see this kind of curving of the meniscus. That's all due to surface tension. Now, if you don't have surfactant, then basically what happens is that your lungs are going to collapse. Another thing too that we're going to talk about when we get into like pulmonary function tests, you're going to see that you're always going to have a little bit of residual volume within your lungs. When you breathe out and you exhale completely, there's always going to be a little bit of oxygen or air left within your lungs. That air is going to serve an important role in helping to keep your lungs inflated. Even with surfactant, if you were to remove all that air, eventually those alveoli would collapse. There are certain animals that don't have any sort of residual volume, like birds, for instance. They can have like constant breathing, which allows them to maintain flight and to maintain their metabolic demands. But for us, we do tidal breathing in and out, so we have to maintain patency of those alveoli. So the residual volume that we're going to talk about later on in this chapter is important, as well as the presence of surfactant. And then this is a research article that I included on here talking about exogenous use of surfactant. If you have a neonate, I know probably some of you are probably going to want to work in like NICU, right? So if you're working in NICU, which is neonatal intensive care, you're going to be seeing this a lot because a lot of those kids are born premature. They're not going to have enough surfactant, so you're going to have to administer exogenous surfactant, which helps to prevent things like pneumothorax. It also helps to prevent different types of infections, and I guess most importantly, helps to decrease neonatal mortality. So, all right, let's do some quizzes questions, and then we're going to skip over into the second half of chapter 22. Looks like the class shrunk a little bit. Did it feel cramped in here on Tuesday? Dr. Premax sent me a photograph. It looked like a little party was going on. Yeah, a little bit of FOMO. Felt like I was missing out. All right, if you didn't log in, then just give us your name at the end. Yeah, that should have been a super easy question. All right, awesome. Most of you guys got it right. All right, good. Not trachea. Trachea is going to be lower respiratory. Sympathetic activation is moderated by beta 2 receptors, yes, resulting in bronchodilation, okay? Not bronchoconstriction, bronchodilation. You want to get more air and oxygen into your lungs as possible. Good. Excellent. Most of you guys got that correct. Yeah, type 1 pneumocytes, those are just going to be simple squamous type cells. And then type 2 pneumocytes are the ones that produce surfactant. Good. All right. Now, here's my question. How many primary bronchi are going to be associated with each of those sides? How many primary bronchi are going to be on the right versus and left lung? Primary bronchi. One into each. And then what about secondary bronchi? Good. Okay, good. Don't get those confused. Primary bronchi, you get 2. Secondary bronchi, where they bifurcate, those are going to be corresponding with each of those lobes. So right side, 3 secondaries. Left side are going to be 2 secondaries. All right? Wow. Okay, that's, that's definitely across the board there. All right, so someone is deciding to, I don't know, take fentanyl for the first time without realizing that fentanyl is extremely dangerous and deadly. Why is fentanyl and opioids, why are they so dangerous? Why do they cause overdose? What happens when you overdose on an opioid? Do any of you guys know? What happens to your respiratory rate? Do you think it goes faster or do you think it goes slower? It goes really slow. The patient goes into respiratory depression. They start breathing really, really slow. When they start breathing really slow, what happens? Oxygen goes down, and what goes up? Carbon dioxide, right? Carbon dioxide levels go up. When you have carbon dioxide levels going up, we call that hypercapnia. Hypercapnia, okay? If you're hypocapnic, that means you have very low carbon dioxide levels. Right? If you're hypercapnic, you have a lot of carbon dioxide. What happens to your pH when you're hypercapnic? Does it go up or down? pH? Up or down? pH goes down, right? You become more acidotic, right? So if you're hypercapnic, you're acidotic. So a patient that's overdosing on fentanyl is going to have acidosis, and they're going to be hypercapnic as a result. Okay, so that's the biggest concern with opioids. Another big concern about opioids is that a lot of people who take heroin and opioids, sometimes they mix them with other drugs. When they mix them with other depressants, like alcohol or benzodiazepines or Valium or Xanax, that's a death sentence for a lot of people. So when people do opioids, it's best not to mix those drugs with other downers. It's best not to do those drugs to begin with. So, all right, let's end that. And then we'll continue on with chapter 22, part 2. So we're not really talking about tuberculosis so much in this class. That's more for like microbiology. We didn't get into it. Does anybody know? Out of curiosity, I want to see who won. I guess it doesn't matter. I missed it. All right, tuberculosis. It's still a very significant illness in the world. Not so much here in the States. You still do see cases of tuberculosis here in the United States, but it's going to be affecting a lot of patients in like highly dense populated parts of the world, places that don't really have great access to, sanitation, poor infrastructure, places like that. In terms of like leading causes of death, where do you think tuberculosis sits? 0 to 20. Huh? 7? Not that high. It's actually considered the 13th leading cause of death globally. So tuberculosis is still really a huge burden on global health. But like I said, not so much here in the States. A lot of times, you're going to see it in places that are overcrowded, like big cities, like for instance, some big cities in India. Even when I was living in the UK, when I was doing my surgery and pediatrics rotation in the UK, there was a huge concern about TB there because the tubes, right, the subways, people are all cramped up together. There's people visiting from all over the world. So those tubes can turn into like petri dishes, basically. And so tuberculosis was a huge concern for that. They used to call tuberculosis, it consumption because it would literally just consume you. You would just be wasting away. One of the hallmarks of tuberculosis, besides hemoptysis, right, where you're coughing up blood, is unintended weight loss. That's one of the big hallmarks of tuberculosis. If you have a patient that they've been coughing a lot for a long period of time, they've been lethargic, and then all of a sudden they start losing a lot of weight, you're thinking tuberculosis. Okay, so those are some of the hallmarks of that disease. So we already talked about the structures of the alveoli. You got the alveoli it's themselves, and then you got the alveolar sacs. You also have alveolar ducts. They're all going to be surrounded by capillary beds. You're also going to see elastin and smooth muscles. Okay, so elastic fibers help to recoil after inspiration, so it allows for expiration. So, and then if you looked at a histological cross-section, you should be able to identify what these different structures look like. So, for instance, little tiny holes, those are the alveoli. Bigger hole, that's the alveolar sac. If you see a channel, that's going to be the alveolar duct. And then you'll see the bronchi. If it's a small bronchus, it's going to have cartilage associated with it. If there's no more cartilage, then that would be considered a bronchiole. So here's another image of what those look like. So you got alveolar ducts, you got the alveolar sac, and you got the individual alveoli. So moving on. So as we mentioned already, type 1 pneumocytes, right? Those are going to be your simple squamous cells that just allow for simple passive diffusion. You're also going to have endothelial cells, which are going to be associated with your blood vessels, right? So those are going to be your adjacent capillaries where blood can get oxygenated, or it can also release carbon dioxide, so that carbon dioxide can be exhaled. And then you also have a basement membrane that's between those, and it's all going to be very, very thin. You want those spaces to be very narrow, so it just allows for easier, simple diffusion to take place. These regions, when you get different types of infections, like pneumonia, for instance, these regions are all going to be affected, right? So if you have pneumonia, you get fluid accumulation in those regions. It makes it so those areas are now like thicker, so you don't get an easy, simple diffusion of carbon dioxide as well as oxygen across that barrier. So the biggest thing that's going on here is simple diffusion, right? So you have that very short distance, and oxygen, carbon dioxide, those are lipid soluble. So they can cross directly across the squamous epithelium very easily. So nothing really too crazy there. And if you have any sort of inflammation, that's, again, pneumonia. This image right here, that's a very dramatic case of pneumonia. We call that, quote unquote, lobular pneumonia or lobar pneumonia. It's affecting the entire lobe of the lung. Generally speaking, pneumonia is not going to be as dramatic. It's going to be a little bit less dramatic. You'll see, like exudate. You'll see like infiltrates on an X-ray, but if you see lobar pneumonia, that's what it looks like. It's very aggressive. We already talked about the different causes of pneumonia, but you're going to, when you guys get into clinical practice, you're going to hear what we call the alphabet soup of pneumonia. There's community-acquired pneumonia, or CAP. There's hospital-acquired pneumonia, or HAP. There's healthcare-acquired pneumonia, which is going to be with long-term patients. There's also ventilator-associated pneumonia, so VAP. So they call it the alphabet soup because it's all different acronyms. But when you see community-acquired pneumonia, that's pneumonia that was acquired out, in the wild, out in the community. Generally speaking, it's going to be Streptococcus pneumonia. That's the number one cause of bacterial pneumonia. Hospital-acquired can be a ton. There's like Legionnaire's disease. There's also like ventilator-associated pneumonia, like Klebsiella that we talked about earlier. If it's hospital-acquired pneumonia, that's after the patient's been inpatient in the hospital for about 48 hours. After 48 hours, if the patient starts developing symptoms of pneumonia, then that's going to be officially diagnosed as a hospital-acquired pneumonia. So, moving on. Let's talk about the interstitium. Now, the interstitium is going to play a really important role in allowing for exhalation, right? So it's going to allow for inhalation and exhalation. It's going to be elastic fibers, elastin specifically, that's going to allow for recoil. So as you breathe in, right, you're going to stretch those elastin fibers. As you now begin to exhale, just passively, you're going to see those elastin fibers recoil, and you're going to expel air as a result. Now, let's talk about the pleura. So there's going to be two major pleuras. There's going to be the parietal pleura, which is going to be what's associated with the thoracic cavity, and then there's going to be the visceral pleura, which is basically what's connected to the lung itself. And then within the visceral and parietal pleura is going to be the pleural space, or the interpleural region. And by the way, in that pleural space, that space is technically supposed to be a vacuum. The pressure within that space should always be less than the pressure within the alveoli, right? So if you don't have that pressure in that space, if you had a greater amount of pressure, for example, then you start seeing things in there, like air maybe, right? If you ever heard of a pneumothorax, that means you got air into that interpleural space. If you got a hemothorax, where you get blood entering into that interpleural space, then you're going to see that pressure going up. Right, so ideally, though, in a healthy individual, this space should be basically negative pressure. It should be a vacuum. And we're going to talk about that in a little bit. So that's the interpleural pressure. It should basically be a vacuum. You're also going to have fluids in there, so when you're breathing, you're not causing any sort of like friction. You're not causing any abrasion to those tissues. So it's going to serve as a lubricant as well. And then, importantly, as I mentioned, it's a vacuum. It shouldn't really be much of a space there at all, right? There should be nothing there. It's supposed to be a potential space. But if you do get fluid in that area, that could be a result of like hemothorax, for instance. So infections can also cause that. If a patient has pulmonary edema, they can also start getting fluid collecting into the interpleural space. So those are all concerns. By the way, about 7 months ago, my wife was in the hospital, and she was on IV fluids, and they overhydrated her. They gave her way too many fluids than she needed. She actually developed pulmonary edema as a consequence, and because of the pulmonary edema, the fluid actually leaked out into the interpleural space, and so she was having all sorts of issues like difficulty breathing and whatnot. Thankfully, she got a lot better, but just know that fluid, there should be a little bit of fluid there just to serve as a lubricant, but not too much. So let's talk about ventilation. So a couple things here. Let's just go through all of these. So when we talk about ventilation, I just put this little chart up here because when you think of ventilation, you're just thinking of the mechanical flow of air going into those areas. All right? So that's ventilation. It's just the movement of air. Respiration is different. That's going to be physiological. Okay? So if you have respiration at the level of the alveoli, that's considered external respiration. Think about that for a second. External because the alveoli are technically sort of in contact with the external environment. Okay? As you breathe in air, it's coming in from outside, it's coming into your alveoli. So that's going to be considered external respiration. All right? Once you get to the level of the cells and the rest of your body, the peripheral tissues, that's going to be considered internal respiration. All right? So that's going to be the level of the cells between the red blood cells and then the rest of the cells that are trying to get oxygenated as a consequence. So to begin with, in your respiratory system, you have pulmonary ventilation. That's literally just air coming in and out of your lungs. After that takes place, then you have external respiration, right? That's going to be at the level of the alveoli, okay? Then, when you get to the circulatory system with the rest of the body, then you're going to have the transport of those gases, right, through your blood vessels, through your arteries especially. And once they get to the cells, then you're going to have internal respiration. That's between the red blood cells and the other cells that are being oxygenated, right? So that's going to be internal respiration. Make sure you know the difference between all those different terms because they're going to be very important for your next exam. So let's go into Boyle's Law. I know that Dr. Premack sort of went over this, but let's go over it again just to reiterate everything that you guys talked about. Boyle's Law is pretty straightforward stuff. Let's just think of a cylinder of some sort. Okay, so like a hydraulic system. So with a hydraulic system, if it were just gas instead of fluids, because hydraulic means hydro, it means water. If you had gas in there instead, so it'd be like a pneumatic system, I guess. I don't know if that's the proper terminology or not. But if you had gas within a contained space, if you were to apply pressure on that space and you were to reduce the volume of that space, the pressure within that space now goes up. So volume went down, right? That's the overall volume of that space. It went down. However, as a consequence, pressure goes up. So it's an inverse relationship. So that's what Boyle's Law is. As you reduce the overall volume of a space, the pressure within that space is going to go up. And then the opposite is true. If you increase the overall volume of that space, you're going to reduce the pressure. So increase volume, increase V, reduced pressure reduction in P. So pretty straightforward stuff. Nothing really too crazy. But that's Boyle's Law. Okay, make sure you commit that to memory. The other ones that we're going to talk about later, Henry's Law, for instance, we'll talk about that when we meet after spring break. So, in terms of mechanics of breathing, now, atmospheric pressure, that's how we measure pressure. Atmospheric pressure at sea level, okay? So this changes depending on elevation. If you're at higher elevations, if you're like hiking the Andes or something like that, if you go to Machu Picchu, atmospheric pressure is going to be reduced, right? So you're going to have a reduction in atmospheric pressure. If you go down to the bottom of the ocean, your atmospheric pressure dramatically increases because of all the weight from the water, okay? But atmospheric pressure is going to be a measurement at sea level, and that's going to be 760 millimeters of mercury, okay? So that's 1 atmospheric pressure. Now, the way that air is able to move in and out of the lungs is going to be changes in atmospheric pressure. Now, it's all going to be due to pressure gradients. So if the atmospheric pressure around you is higher than the atmospheric pressure within your lungs, then the air is going to follow that pressure gradient. It's going to go from high pressure to low pressure. That's how air is actually able to enter into your lungs. Air is not going to be sucked into your lungs. It's going to be pushed into the lungs via atmospheric pressure and that change in the pressure gradient. Okay, that's one really important thing to keep in mind. So let's talk about that in more detail. The majority of what dictates and determines your intrathoracic pressure and the pressure within your alveoli is going to be your diaphragm. That's going to account for about 75% of all the movement of air. Now, as your diaphragm, so your diaphragm is going to be a concave shape, right? Or is it convex? I guess it really just depends on if you're looking at it from the top or the bottom. But it's curved, right? So that's going to be in its relaxed position. As the diaphragm contracts, it's going to straighten out, right? And as it straightens out, that's going to actually increase the overall volume in your intrathoracic cavity, right? And what happens? When you increase the volume, pressure goes down, right? So that's Boyle's law. So what's going to happen is that now the atmospheric pressure outside is going to be greater than what's inside, and so the air is now going to be pushed into the lungs. And then the opposite is true. When you expire, right, when you're exhaling, right, probably a better term than saying when you're expiring. When you exhale, your diaphragm is relaxing, right? So when your diaphragm relaxes, it's going to go back to that curved shape. Okay, so that's going to reduce the overall volume within the thoracic cavity, and that's going to reduce the volume. It's going to increase the pressure, so now air gets pushed back out. Okay, so pretty straightforward stuff if you understand like the simple concept of Boyle's law.
Breathing movements. Inspiration. The pressure in the lungs is decreased. The air rushes in. The muscles of the diaphragm contract to make it descend. The rib cage moves upwards and outwards. Expiration. The pressure in lungs is increased and the air is pushed out. The diaphragm becomes dome-shaped, relaxes, and moves up. Simultaneously, the rib cage moves down and in.
All right, so that's super riveting video that just basically reiterated what I just told you. So here's another summary of what that looks like. With inhalation, your diaphragm contracts, increases the volume, decreases pressure, air gets pushed in. Exhalation is just going to be the opposite of that. So pretty straightforward stuff. And here's kind of an image of what that would look like. Now, I'm not going to play this video. This video is actually extremely obnoxious. So if you want to watch it on your own time, by all means do so. But I'm not going to play it in this class because they're showing lungs lungs inflate in front of a bunch of children, and the children start like applauding and stuff, and they get kind of it hurts my ears. So the interpleural pressure. Now remember, interpleural space, that's supposed to be negative pressure. It's supposed to be basically a vacuum. Right? So if you get a pneumothorax, one of the things that you do to treat a pneumothorax, you have to put in a chest tube, and you have to try to recreate that negative vacuum pressure. Right? So that's one of the big things if you get air trapped into that interpleural space through a pneumothorax. Generally speaking, it's going to be about 4 millimeters of mercury less than the interpulmonary pressure. Right? Interpulmonary is going to be within the lungs. So let's go into it some more here. So when you're inspiring, you're going to be reducing the interpleural pressure, right? So that interpleural pressure is going to be on the outside, right, within the pleura. So as you reduce the interpleural pressure, you're going to have a volume of the thoracic cavity is going to increase, right? And that's what allows for air to get pushed in. And if you reduce interpulmonary pressure, that's going to allow for expansion of the lungs, and that's going to be associated with expansion of the visceral pleura as well. And then here's another thing that I was mentioning earlier with the warming of air. That's going to be extremely helpful in allowing for proper oxygenation. So oxygenation as well as the inflation of the overall thoracic cavity. So think about the expansion of air, right? When air warms up, it expands, right? So if you're like driving along, your tires start getting hot from the friction, the PSI within your tires is going to start increasing as a consequence. Same thing when you're like breathing in through your the nasal concha, it's all warming up the air. That's going to also aid in the expansion of the alveoli as a consequence. Now, when you're just sitting there doing regular breathing, you're not exercising or anything, we call that normal tidal breathing. That's when you're just not even thinking about it, right? That's your breathing in, breathing out. It's going to be roughly 500 milliliters of air per breath. So that's going to be normal tidal breathing. Let's talk about some more of the way the dynamics are working. So this is the interpleural pressure. As you notice over here on this margin, the pressure overall is going to be less than the pressure in the interpulmonary area. So the interpulmonary pressure should be basically 0 at rest, whereas the interpleural pressure is going to be a few millimeters of mercury below that. So it's basically a vacuum. And then this is your tidal volume. That's breathing in and then breathing out. So it should be roughly 500 milliliters of air. And then this is the last thing we'll talk about before we close. If you start exercising, or if you're a patient undergoing respiratory distress, right? If you have respiratory distress due to anything really, you're going to start using accessory muscles. The accessory muscles are going to be all the muscles that can also help in breathing, but when you're doing like forced inspiration, forced expiration. So all those accessory muscles, sternocleidomastoid, scalenes, serratus anterior muscles, which are going to be the ones just lateral to your thoracic cavity. All those muscle groups are going to activate if you're undergoing respiratory distress or if you're just exercising. If you're forced expiration to be able to bring air back out of your lungs, sometimes you might start using your rectus abdominis. You start using your abdominal muscles to be able to help push all the air out of your lungs. But the most important muscle of all these is definitely going to be the diaphragm. So that's responsible for about 75% of all the movement.